I'm Peter Ekman. I'm the head of the Advanced Heart Failure team at the Minneapolis Heart Institute, and was very grateful to be invited to join the presentations today by Dr. Berlakis and Saraja. In the interest of full disclosure, I'm a fish out of water here, being a heart failure cardiologist and a meeting with a lot of interventional cardiologists. I can spell stent, but I've never put one in. And as I was telling these guys earlier, I knew when I was a fellow I wasn't going to be an interventionalist when I would be excited about a normal coronary angiogram, because then I could go on and do a right heart cath. So that being said, I'm really glad to be here today to help continue the discussion about cardiogenic shock, which is obviously something that's an area of substantial overlap between our teams. So I will start, and then we're really grateful to have some real leaders with us on the panel this morning. So here we go. And I want to thank Philips, Teleflex, and Terumo, W.L. Gore, Assist, Sahi, Pfizer, and Cook. How do I escape here? There we go. Relationships I've had are with both Abbott and Medtronic as a consultant, and as I'll highlight on one of my subsequent slides, all honoraria are donated to our research foundation. I've been asked to provide a quick overview of cardiogenic shock today, and I will say that giving a talk on a topic like this in 8 minutes is kind of a challenge. I think most people know the way this is typically defined in terms of end organ perfusion from low cardiac output, typically also citing a low cardiac index and or high pulmonary capillary wedge or end diastolic pressure, hypotension and or need for supportive measures. About 5 to 10% of acute MI cases are complicated by shock. This has not changed appreciably over time. And depending on the references you look at, most have suggested the in-hospital mortality is in the 50-ish% range. There are some that have noted that it was perhaps higher in the past and has improved somewhat, which we always like to see. In terms of diagnostic tools, they range from the mundane vitals exam, urine output, to the laboratory tests, pH, lactate, chemistry panels. Echocardiography can certainly give clues. Ejection fraction alone certainly does not define this, but one thing people will sometimes use is an LVOT velocity time integral. And obviously, I'm a big fan of the Swan-Ganz or pulmonary artery catheter, which is a critical part of this. And I think one of the things that I was gratified to see in some of the work from Dr. O'Neill and his team in the National Cardiogenic Shock Initiative was suggesting that patients that had hemodynamic monitoring may have had some benefit. As a heart failure cardiologist, we often get criticized of why do you use so many PA catheters, and people cite the ESCAPE trial, which has some important pitfalls to it, but I was, of course, gratified as someone who's a PA catheter enthusiast to see growing support for the role of hemodynamics in decision-making of these patients. When we treat patients with shock, revascularization's been certainly very well established, and that would be the proverbial bringing coals to Newcastle for me to presume to tell interventionalists how to revascularize people. But I think one of the debates that's really coming to the fore is whether or not revascularization should be done before or after mechanical circulatory support, and the US PELA registry is suggesting a benefit, and I'll make a couple more comments about this later. In terms of medical therapy, as the sort of proponent of medical therapy here today, I'm here to say that what we have is a little limited, and the data on it is pretty embarrassing. We use volume management, optimizing preload, diuretics, or volume, controlling blood pressure and heart rate to try to minimize oxygen consumption. Obviously, some of the pitfalls of this include if you use an inotrope, those can actually increase oxygen consumption. They can be arrhythmogenic and can have, pressors can have an adverse effect on microcirculation, all of which can decrease tissue perfusion and increase acidosis. Mechanical circulatory support obviously then becomes of some interest, and as someone who's one of my primary interests is in durable ventricular assist device support, I'm certainly a fan of this, and it's something that we use a lot in our interface with these patients. Balloon pump has been around for quite a while, but the studies on it have been disappointing, and it's actually considered a Class 3 indication in European guidelines. We also have devices like ECMO, Impella, Tandem Heart, and the pitfalls from these devices can include the risk of bleeding, limb complications, and access issues. These are enormous cannulas. One of my friends who's an interventional cardiologist tells me that every time he puts someone on ECMO, he feels like he's taking a spear and stabbing them with a giant spear. And so this is certainly a dangerous thing that we do to people, but there are also folks that have a very high risk of mortality without aggressive treatment. Based on currently available data, there's no clear winner in terms of the right device or the right approach. In terms of medical therapy, I did a bit of a literature search here to see what I could find supporting this, and thought, well, I'll go to the Cochrane Review there, let's see what they have to say. They found 13 studies with over 2,000 participants, but 1,700 of these were from a levosimendan study. And overall found that there was low quality evidence suggesting a short-term mortality benefit from levosimendan compared to dobutamine. Everything else was inconclusive, including comparing levosimendan to placebo. So one could argue that we have essentially no data on the use of medical therapy in cardiogenic shock patients following acute MI beyond revascularization. So there's certainly no convincing data to support this, and this is something that I would say is on us collectively to look for opportunities to improve the evidence base surrounding this. And of course, one of the challenges is that nobody's going to sponsor a gigantic randomized trial of furosemide in these patients because they're complicated patients. It's an expensive trial. It's a drug that's been around forever. So there's some practical reasons why this has been a challenge. Acute mechanical circulatory support, there's two large strategies in the face of the fact that balloon pump is, the data has been declining, or is at least not as aggressively supportive. The first is the Tandem and Impella camp, and the other is more the ECMO camp, and it's a little bit like politics. On some level, you sometimes see some disputes and strong feelings on either side of the debate, but I think we really all can get along, and there's a lot of room for us to work together. One of the studies that I thought was interesting looked at the outcomes. It was a meta-analysis of 4 trials comparing mechanical support, Impella and Tandem Heart with the balloon pump. And this was a short-term follow-up from this pool of studies. All-cause mortality was virtually equivalent, but there clearly was an improvement in the hemodynamic level of support that you saw from mechanical devices. Higher MAP, the index and wedge were not different, but lactate was better, and there was a higher risk of bleeding. And here's the graph showing the dispersion of the different studies. And so I think what I take away from this is that there certainly is some evidence suggesting that the mechanical circulatory support options are more powerful in terms of their hemodynamic benefit. There have been studies looking to try to help us understand risk stratification. I think one that I thought was interesting and is potentially very useful, in that it's my friend and colleague, Dr. Nick Burke, who I don't know if he's still in here, if he had to run, told me that I needed to use short sentences because I was talking to interventionalists, and of course that's not true, but I can very much appreciate the idea of concise risk scores, and this is one that I think has some potential for us to make some upstream risk stratification predictions. Also wanted to note in terms of what else has been published and available in randomized studies, the IMPRESS study, I suspect most of you are familiar with, was almost 50 cardiogenic shock patients after acute MI randomized to percutaneous support versus a balloon pump. High percentage of these patients with arrests, very high lactate. I think that arguably is one of the potential criticisms of the study, is were these patients too sick, and should they have more of them gone on to ECMO? Again, found roughly a 50% 30-day all-cause mortality. As I mentioned earlier, one of the debates that I think is flaring up and in a good way, and this is from a review that was just published. In fact, I got the date wrong. It's from 2018 because it was just published here earlier this month. Dr. Kapoor was one of the co-authors in this review by Nir Uriel, who's a heart failure cardiologist at the University of Chicago, highlighting the potential benefits of unloading first to minimize or improve oxygen demand, and hopefully that may reduce infarct size. And so there is a trial that's ongoing, as I understand it, has completed enrollment to compare whether or not unloading prior to revascularization offers an advantage in terms of infarct size. So I think, as I see it, there's a number of unmet research needs in this field. It's a little puzzling on some level that the hemodynamic improvements of mechanical support haven't led to a clear and convincing mortality benefit, although there's some hints of signals of that. And I think that the work that the National Cardiogenic Shock Initiative has been doing is clearly increasing people's interest in this and is suggesting the potential for improvements. Large randomized trials in medical management, as I said, just haven't been done, and there's very little out there. A lot of the work that's been done is being driven by the acute coronary syndrome population, and as someone who takes care of the full spectrum of heart failure patients, there's a lot of people that have cardiogenic shock that didn't start out in the cath lab, and so I think that's another area that I hope that we as heart failure cardiologists will be assertive in participating in that process. Risk stratification gives us some potential for deciding on the triage of what device when and how aggressive we should be and when. I think there's also merit. These are very expensive therapies in making sure that we are judicious in terms of when we deploy them, but that's very difficult to say. It's been argued if you have a patient that comes in that has let's say they have a 75% chance of dying if you, even if you intervene and are effective, but they have a 100% chance dying if you do nothing. So that 25% increase in survival is a number needed to treat 4 patients. So I think it's easy to make the argument that the sickest patients are the ones that may merit the most aggressive approach. And it's also been suggested, and I can't take credit for this, although I have to admit I don't remember where I first heard or read it, whether we should be testing a strategy as opposed to a specific device of unloading, for example, or lowering filling pressures, reducing oxygen consumption, and letting centers decide based on their local expertise of what's their best approach of how to achieve that strategy, much like has been taken in the septic shock population. So I'll stop there and we'll move on. I would like to next introduce Dr. Ajay Kurtain, and we'll get your talk teed up for you here. On,
we have a few minutes actually.
Oh, do we? Okay.
For discussion. That's a very good overview. I think, we're struggling as a field to identify shock, and what do you think of all those things you mentioned? What do you think is the rate limiting step here? Do you think we're not defining it properly, or we're catching it late because of that definition? I will tell you, I'll speak in my lecture that we are, Naveen is on this as well. We have a new consensus document coming up by SCAI and HFSA together with critical care, emergency medicine, and surgery, and nursing as well, on how to define shock and to try to subclassify this to earlier initiation of, early identification of shock, pre-shock, and do you think part of the problem is really that by the time they come to the lab, we really fail to recognize it appropriately and catch these patients early enough?
I think that's clearly one of the factors, and definitions are really essential, and that's something that we in the heart failure community are struggling with in the heart failure preserved ejection fraction population, that we've been studying this as a single large entity, and it's probably some different subgroups. But agreeing on the definitions, I think, are essential. Something that's simple, that's easily identified, and that's associated with adverse prognosis, then helps us not only identify it but recognize that this is an emergency and this is something we need to react to quickly. So I think that's an important step. These are very sick patients, which doing clinical trials in such sick patients is always challenging as well. So I think that's been another pitfall. And then in the medical arena, as I alluded to, I think the financial incentive for some of the studies isn't there in the same way that it is for devices, where there's more of a financial incentive, partly because they're more expensive. So I think those are, as I see it, some of the biggest obstacles.
Others on the panel, what do you think the rate limiting step here is?
Yeah, I think the problem with shock, most of the time we depend on tools are not readily available in the ER and in a hospital world. Without deep measurement of the cardiac output, you cannot understand why the patient has low blood pressure. And it could be multitude of reasons, and you could have low blood pressure but still have a good cardiac output. So. And it's kind of moving targets for us, and we still do not have a concept of the hemodynamic deficit, like there are patient and other patients. So I think your work and Naveen's work in that field, it's a tremendous, and I think we still have ways to go in that.
Yeah, so I would say that for us, for the next 10, 20 years, shock is the new STEMI. And that's how I would think about it, is that, we've developed phenomenal programs for STEMI management, and we've really moved the dial on in-hospital mortality. The difference, of course, is that the adjudicator for STEMI is an EKG. And if only shock came with an EKG, but it doesn't. And so I think the first step is identifying what's going to be the most common, simplest way to identify patients in shock. But then comes all of the structure building around the algorithm for how this should really be treated as a door to balloon time, very similarly a door to support time. And that's, again, one of the major messages from the CSI program.
Okay, great. So Ajay, take us through all the different devices.
Yeah, so I mean, I think that comment, leads perfectly into this talk. And I was initially given the task of when to use hemodynamic support and device selection in shock simplified. And I'm going to tell you that I actually don't think that it is that simple. I think you have to be thoughtful about this. Patients are dynamic, and we have to adapt what we do during the course of these cases. And I'll show you some case examples in order to support that. This is a slide from Naveen showing you what the spectrum of devices there are out there. Basically, left ventricle, right ventricle, and variety of devices for each. And this is one of the reasons why I don't think it's so simple, because there are different devices, and none of them are good, bad, or otherwise. I completely agree with your slide that you showed. It's just you have to pick the right time for each one. The fundamental principle, though, is we know that as your cardiac power output is lower, your outcome is worse. And the way you can determine this is by looking at the blood pressure and by measuring the cardiac output. And so every single one of us up on the panel is going to tell you repeatedly that you need to do Swan-Ganz catheterizations to figure this out. And you need to do them dynamically and adapt to things in real time. So this is just an example of a 46-year-old gentleman who was ultimately transferred to us, who presented to an outside hospital with what was billed as DKA/honk. And on arrival, blood pressure was 100/60 and the heart rate was 110. He had elevated JBP, crackles, and no murmurs. And I think most people, if you look at this type of patient, we see these patients a lot in every hospital, every ER, every day. And this patient is not a patient you can tell right then what's going to happen with them. The patient can evolve one of two ways. They're either going to get better or they're going to get worse, and in some cases a lot worse. Most people would say this patient's probably not in shock, but we don't know that until we make other measurements. Lactate's 2.3, creatinine's 1.2, blood gas shows some metabolic acidosis, and he's got pulmonary infiltrates on his chest x-ray. So if this patient is acted upon very, very quickly and diuresed and turns around, you're never going to be in the shock paradigm. But on the other hand, if this doesn't get better, then he's going to be in a different direction. And the idea of when we institute support has to be based upon this premise that we're assessing the patients frequently and we're trying to see what their trajectory is. And as we start piecing together the time points, then we can figure out what to do. So what happens in this case is he deteriorates, he has more respiratory distress, he now has ST elevations, troponins are on the rise, and he comes to the cardiac cath lab. I'll show you the angiography, which demonstrates multivessel disease. There's slowish flow globally, but there's not one clear culprit vessel, if you will. It's basically, the culprit is the ventricle. The myocardium is suffering, and as a result, the end organs are about to. And so this is just his LAD and his circumflex. His, not the greatest V-gram shows that the EF isn't awful, but it's certainly not normal, and then he's got diffuse disease in the right coronary as well. And so what I would say would happen in a lot of hospitals here in the United States is the patient would be stabilized and a balloon pump would be inserted, and then surgical consultation or PCI deliberations would then ensue. And that's actually not the wrong thing to do in many of hospitals that don't have more advanced support. The reason I say this is because many people castigate the use of balloon pumps in cardiogenic shock. And there are subsets of patients, and this is an analysis we published from our Columbia experience, predominantly in chronic heart failure and shock, that show that you can get a reasonable modicum of support, but just not a lot of support in these types of scenarios. So it's not wrong to try it. It's cheap, it's ubiquitous, and that sort of thing. The question is what do you do after that? And do you escalate, and do you have the capacity to escalate or transfer the patient, or should you just put a more supportive device in up front? And what happened in this case is what happens too often here in the US, and what we see here is the patient gets the balloon pump, goes to the unit, pressors are escalated, echo is done, deliberations are made, and then 4 days later, because the patient's not turning around, we get the call, can you do something with this patient? And I call this balloon pump inertia. Basically, you put the patient vented, pressors, IBP, you put lines in, you CVVH, and then you wait and see what happens. And in the current era, that's just not acceptable because we do have other options for these patients. And this emphasizes this point of you need to have a dynamic system with dynamic caregivers to deal with what is a dynamic disease. This patient came in one way, they've changed, and can we adapt to that? So the way we do it in our institution to simplify things is we have a team. And the team has various inputs, all of whom have strengths and weaknesses. And so, this is the heart failure colleague says, the patient's too sick to transfer, but he could be a candidate. We have a bed, so let's transfer. Lots of deliberation on either side. The coronary interventionalist says, we need to look at the coronaries, the Impella is okay, and that's what I'm fixated upon. And the surgeon says, we can send our ECMO team for assessment and transfer, and he sends his ECMO team, which is his junior fellow colleague. So that's kind of how we work, but the reality is that these three different inputs, and in other cases intensivists as well, really enable us to look at these patients dynamically and adapt what happens. This is often how we do it in our institution. They're anonymized group texts, lots of conversation back and forth to pick the right therapy for the right patient in that way. What happened when this patient came over is we put a swan in immediately and noticed several things. One is the filling pressures weren't so bad, the PA sat was relatively preserved, and the blood pressure on pressors was 200 over 110. Okay, so then you can start doing other things. We weaned the pressors, we discussed what the revascularization strategy was, and then we opted for complete revascularization. So to revascularize all three territories in somebody with shock, I think the data is nicely supportive of using more support than less support in that scenario. Why? Because in randomized trials, when you take patients like this and you revascularize them, you make them worse before you make them better because you're making them ischemic when you're doing your PCI. And at least in PROTECT II, for me, one of the most compelling facts of the trial was the fact that the decline in cardiac output, or the decline in cardiac power output, was less with a more supportive device, the Impella, than a balloon pump. And so similarly, if you're doing more extensive revascularization, you need more supportive devices. In the same trial, if you have a limited revascularization, balloon pump may be fine, but in this case, you're opting for complete revascularization. And so that's exactly what we did. We put the device in, the Impella in, and did a full revascularization of the LAD, the circumflex, as well as the right coronary artery. And then this patient, you needed to manage them for several days to weeks afterwards, and the patient did fine and left the hospital. But the idea here is things change with the patient, and we need to adapt to what we need to give based upon how the patient's changing. This is another case of a patient who really only had one vein graft supplying his whole heart. During the diagnostic angio, clot went down the graft, and the patient promptly arrested in the cath lab. VF, no blood pressure, full-blown arrest. Many interventionalists in this scenario fixate on the coronary and they want to open the artery. That's not what this patient needs. The patient needs support, and then you fix the coronary afterwards. And so this was a perfect candidate for a patient to be put on ECMO. So we put this patient on VA ECMO at the time. To differentiate it, VV ECMO, often seen in the ICUs, and we do that as well, is for oxygenation only. VA is for support. The downside of that support, though, is that you have a typically 15 or bigger French cannula in the arterial system, so you typically need distal perfusion. Patients require lots of transfusions, but it is life-saving in these types of circumstances. And in this case, it was the only way that we were able to do the intervention, which required a guideliner all the way down the graft with then a delivery of a stent in this way to supply the heart. So without that, without putting the patient on full support, there's no way this intervention would have been done, and then this patient had a good outcome in the end. There has been a shift, and Naveen alluded to this, in the use of MCS. This is a review paper in JACC showing that basically in the old days we would wait for the patient to crash and then institute support. What we've tried doing now is to prevent that from happening by instituting support at earlier and earlier time periods. Now, there are downsides to doing that, but the upside is we can potentially salvage the heart. This is adapted again from Naveen, who really honestly, the reason I use his slides is because he's led the field, and I think I've learned a lot from listening to him talk, and so hopefully you all will learn the same. But basically, this slide also shows you that it's not that one device is terrible and the other ones are good. It's that certain devices can be used for certain indications. And you need to diagnose the patient first to then decide which approach to use, and in some cases, you're using multiple devices as well. I want to really caution everybody to be cognizant of the bleeding complications associated with these devices. These are not trivial. There's a lot of transfusions, and this is the data we published in JAMA Cardiology showing that hematomas, transfusions, and even vascular interventions are very important. We saved a patient last week by putting the patient on first RP Impella, then transitioned over to VA ECMO, now transitioned over to VV ECMO. I had to stent the iliac with a covered stent in the interim. These are cases you invest heavily in, and you really have to go the whole hog to be able to sort it out. Final word, don't forget the right ventricle, because this is all left ventricular support. RV is also very important. This is a patient that we treated, had a 51-year-old inferior MI, reperfused and did fine. We left the swan in. These are the hemodynamics, pre-PCI, Post-PCI, things are looking good. Her SATs are fine, but she's on a little bit of dopamine. Post-PCI day 1, the RA pressure goes up to 20, the wedge is still 16, the PA SAT is down to 28. If you put a left side support device in this patient, you're going to do nothing for the patient. Perhaps if you put them on VA ECMO, you'll unload the RV, but basically in this particular case, you diagnose shock from right ventricular failure and you put in a right side support device, either an Impella RP, Protect Duo, or some other configuration through a Centromag. But immediately after doing this, goes to anuric, starts urinating, inotropes are decreased, and then immediate hemodynamics show benefit, and then this device is weaned and the patient leaves the hospital. So I think just to conclude, the increased awareness of percutaneous options may improve outcomes in GCS. Why do I say may and not does? Because we don't have definitive proof of it. We certainly all operate under this paradigm because we don't just want to give up on patients, but it is important to generate the data, and that's being done. I do think that appropriate management cannot be super simplified and does take a team-based and patient-oriented approach, carefully weighing both immediate and longer-term goals along with the benefits not only of percutaneous support, but even durable support, because some patients are not going to be candidates for that, and that may change your upfront options of what you do. I think balloon pumps can have a stabilizing role, but it's stabilizing only, and frankly, for more supportive cases, more sick cases, you need more aggressive support in those cases, and typically, especially for interventionalists, percutaneous options tend to be the best approach. I do think ECMO works, and it's good for total crash and burns, but remember about the vascular complications, the transfusion requirements, and beyond. And then finally, the availability of percutaneous RV support has further expanded our options in armamentarium, and you need to be very familiar with that as well. Thanks so much.
So we have a few minutes for questions. Are there any questions from the audience?
Hi, Burke from Minneapolis. Outstanding talk and coverage of a very complex subject. It seems to me that the vast majority of the problems is our inability to recognize the shock before it becomes a critical issue. And does that mean, you know, every patient that hits the ED with chest pain gets troponins, EKG? Should they get a lactate? Should they get a venous pH? Do we need to change our algorithms?
Want to take that?
Yeah, I think, you know, there's enough other extraneous tests that get added to every patient that adding a lactate is a very reasonable thing to do. A lot of rapid response teams will do that and do assessments in that way. There's going to be a false positive rate, and we've certainly been called to put in mechanical circulatory support. You bring the patient downstairs, you do a right heart cath, and you know, they're hypovolemic or they're GI bleeding. But that's okay. We made a diagnosis, and it wasn't being made before. So I do think that those basic triaging steps need to happen, and there also needs to be follow-through on what do you do when you actually detect the positivity to then, you know, not over-treat people, but yet actuate a plan.
Another thing, too, that came up in a meeting last night, and I thought I saw Dr. O'Neill here, but he alluded to checking an EDP before he even shoots the coronaries in acute cases as another step. And I don't know if that's something people routinely do, if that's uncommon, but I think that's another piece of data upstream that may say, you know, you get an EDP of 20 that, okay, you move along, but then that's when you also activate more of a shock process. Maybe another way to approach it.
I mean, I think that's a good idea, and we'll talk a little bit later about the competing interests of door-to-balloon versus door-to-unloading, but this is where we get into a situation where there's a culture, but there's also a desire to open the artery very quickly. But also, I think in the ER, you know, we have to figure out how to better assess these. Clearly, we can't just smell it. We can't just smell shock coming. Maybe some people better than others, but we probably had to put in some types of protocols to catch these ahead of time. And then there's a resistance. These devices are still difficult. They still add a whole complexity in terms of how long the patients are in the hospital, the potential complications, vascular and otherwise. So there's an inherent resistance and a sense that maybe we can get away with some of these things without it. And so I think we have to sort of overcome that hurdle, I think.
Yeah, just to add a couple of things to this great interchange. When we identify these cases and present them at the conference, it becomes kind of clear for every single case what was missed to a way that actually should be very simplistic. When you're evaluating these cases prospectively, it's totally unclear because for various reasons, actually quite practical. One is these devices can go in but they cannot really exchange them easily one another. Let's say you have a patient on a balloon pump, you want to upgrade. It's not extremely easy to take it out and put it in. Maybe that's easiest. You have a patient on an impeller, you want to upgrade to a higher level impeller. Well, you have to use another groin. It doesn't come out over the wire easily and all that. Similarly, you want to go to an ECMO. It is not, again, a very easy escalation. Let's say you want to do a PCI and then you want to go for an LVAD. Then the surgeon is going to be upset, the patient's on Brilinta or Plavix or something like that, how they're going to do their LVAD implantation with all of that. So the strategy becomes, in the end, very, very important. And we wish we had something like a STEM EKG. And again, you see how many things we miss, even with a very simple STEM EKG, the way from what we're discussing now. So unless we kind of figure out the best way to kind of triage cases up front, but take under account all the possibilities. You cannot just put something that requires anticoagulation and later on, maybe an hour later, realize, oh, this was primarily a bleeding-related event. That's an embarrassment. So all those are really conflicting with each other. Whereas with STEMI and non-STEMI area, even if it wasn't a non-STEMI, at least we knew it was some kind of a STEMI. Over here, we have so many conflicting things, and also with aging populations we all face these days, access is becoming also a significant consideration. It's like, sure, I know I want to use that, but our 80-plus patient or 70-plus patient is really not a candidate for that for various other reasons, or you try and you end up in a complication. So there's a lot of, the pathway is very complex, much more complex, and unless we start from the very beginning, and we obviously going to have to make some mistakes along the line and then correct ourselves, is not going to go anywhere. But I think we're more, concerned of the complexity. That's why we're a little bit lost in that complexity for right now.
Okay. With that, I'll ask Naveen Kapoor to come up, and we're going to do a quick little debate, 5 minutes each, and then a little rebuttal. Hopefully this will be a little fun. Thanks.
Great. Thanks so much for having me. It's an honor to be here to present this debate. So I'll reveal that in high school, my first varsity letter was with the debate team. So I'm going to enjoy the debate. This actually is not correct, and I'll have my disclosure slide in the slide deck. So we're going to be talking about something a little bit different. We're going to be talking about the idea of door-to-unload or early mechanical support as a replacement for door-to-balloon as the timing metric for acute MI without cardiogenic shock. So a little bit of the shifting gear in the topic we're speaking about. Those are my relevant disclosures. So I thought I would start with one patient story. This is a patient who showed up in 2007 with an acute MI, anterior MI, had an LAD PCI, balloon pump, did very well in the hospital in terms of survival, so makes it out of the hospital with an EF of 20%. And then begins a 10-year saga of recurrent heart failure, ICD implant, more and more congestion, escalating drug therapy for heart failure, high-risk PCI 2 years later for the LAD and the circ, subsequent readmissions for heart failure, only to come back 10 years later in cardiogenic shock, requiring ECPella configuration and an EF of 10%. It doesn't stabilize, requires BiV Centromags, and then goes on to cardiac transplant. So this is how you can go from a heart attack to heart failure, and this happens over and over again, but the interventionalist stops right here, shows up here, and then shows up here again. So heart failure is an epidemic. By the year 2030, 1 in 33 individuals in the United States will have heart failure, and the total cost for heart failure will reach $70 billion in the United States. And heart attacks lead to heart failure. So in the developed world, ischemic heart disease remains the #1 cause of death worldwide. We know that over the last 4 decades, we've seen a significant improvement in MI mortality, but what we've also seen is an exponential growth in heart failure hospitalization, and the two go hand in hand. And the reason for that is that the size of your heart attack matters. So this is more contemporary data from 2016 showing that for every 5% increase in the era of contemporary primary PCI door-to-balloon strategy, we see that there's a 20% increase in 1-year all-cause mortality and a 20% increase in heart failure hospitalization, just like you saw with our patient. And the median infarct here for primary PCI, any type of infarct, is still around close to 20% of your total left ventricular mass. So comfort is the enemy of progress. That's a classic phrase from P.T. Barnum. And it's important to understand that more rapid balloon angioplasty is not the answer. We've maximized the benefit of door to balloon once we get below 90 minutes, and certainly around the average time we're seeing around 60 minutes. Mortality is flat, but this growth in heart failure is really the target that we're going after. So to change the future, we have to learn from the past. This is a paper from 1971, Eugene Brunwald, Peter Marocco, landmark paper, basically suggesting for the first time that maybe we should be targeting myocardial oxygen demand. But history had a different plan. In 1976, Andreas Runzig was presenting balloon angioplasty. In 1977, first angioplasty occurred. So as a result, we focused on myocardial oxygen supply. But we have to develop new approaches to limit myocardial infarct size. It is our responsibility as interventionalists to start thinking about infarct size as a readout of our efficacy or our therapy. But there are two major hurdles. One is that we have to engineer a device that can actually rest the heart, that can be used clinically, and we've got to have some data. So for 40 years, people have been working on this concept. Remember, the paper from 1971, 1978 was the first dog study using a balloon pump. And since then, multiple investigators from around the world have kept working on this concept of unloading. And the take-home message from all these studies was that unloading before, not after reperfusion, is required to reduce infarct size. And that's the reason for the shift from door to balloon to door to unload. And remember, unloading is a principle. It's not a pump. So this has been shown with the Hemo pump, with the Impella 5.0, with the Tandem Heart, with the Impella device, the CP. So we're talking about unloading, however you do it, and when can you do it safely. So we've also just recently published this past week in that JACC issue that door to unload promotes a completely radical concept that it actually changes myocardial biology to the point that the heart changes over 3,000 genes that start to favor myocardial recovery. And a lot of this biology is now being worked out by our lab and other labs. What we also learned was an astounding observation that's published in that paper. These are your mitochondria and cardiac myocytes in the anterior wall of your LV. When you do primary reperfusion therapy, this is what your mitochondria look like. They're swollen, they've popped, they've got blebs forming in them, they are not happy. If you do primary unloading in that same infarct zone, the mitochondria remain completely intact. And what we've seen from the gene expression profile data is that we're actually changing the way the cell actually has metabolism by putting in a pump. So we ran a preclinical trial. The preclinical trial was the idea of primary unloading versus primary reperfusion. And we showed that 30 days after the therapy, there was a more than 50% reduction in the scar size by late GAD enhancement by CMR as well as by anatomic path. And more importantly, we saw that stroke volume, cardiac output, and LV stroke work were all improved 30 days after primary unloading as opposed to primary reperfusion. And here are some of the MRI images. This is if you have a heart attack with no pump and you're in the preclinical study versus if you had a heart attack and a pump inserted. So unloading before reperfusion is actually something that you're all beginning to do. In AMI shock, it supports the concept of door to unload. And the CSI initiative is built on this paper showing that pre-PCI intervention, so if you actually do mechanical support before intervention, you actually get better survival over time in patients presenting with AMI and shock. And remember, there's growing familiarity and success with rapid deployment, management, and removal of the Impella CP under some of the highest risk conditions. I think the talks here at this symposium have shown that you guys do this in CTOs and TAVR and some of the sickest hemodynamic substrates, including cardiogenic shock. And you're doing this about 75,000 times. And so the experience with this technology has grown to the point that we can now do this in the setting of an anterior MI. So the time to test the utility of door to unload is now. Clearly, there's an inherent need for improved outcomes in AMI. It's not about in-hospital mortality. It's about heart failure subsequently. More rapid door-to-balloon times is not the answer. Door to unload has evolved over 40 years of science, and it's built on fundamental scientific principles. And we're already unloading earlier and improving outcomes for AMI and shock. So this led to the door to unload safety and feasibility study that was approved. And the study design, as the FDA requested, was to take anterior STEMI patients and randomize them to two groups. Everybody gets primary unloading and then gets reperfusion. But what they asked us to do is to test that concept of unloading before reperfusion. And in one arm, we put the pump in and we waited 30 minutes while the LAD stayed occluded, and then we reperfused. And in the other arm, we put the pump in and we immediately reperfused in those patients. And the primary endpoint here is a safety endpoint. And of course, we're looking at some early signs of efficacy as well in the trial. So thanks very much.
All right, so I don't think I can really debate Naveen Kapoor. I've known him for a long time. And I think also we have similar views on a lot of these things. That's what makes these things interesting. So I'm going to take a big picture approach here. I think there's some things that we're missing here that I think should also be addressed. All right, okay, so the issue here is, should door-to unloading, this new concept, replace door-to balloon, a time-tested paradigm? And you know, balloons are more fun, I'll tell you, than unloading. It's a lot more work to unload. I think that's what I was alluding to. We're very good at balloon angioplasty and stenting. This other concept is certainly something that we all are aspiring to maybe use in conjunction, but certainly it's a little tougher. Why is that coming up? I don't know why. Okay. So the real question here is, what is the target? And you've all seen this slide. You know, when cardiogenic shock is initiated, we don't really know when that happens. It's a paradigm. It is a cycle. It is a catastrophe. But it starts with ischemia that can happen and results in systolic dysfunction and diastolic dysfunction. And then as that progresses, you get a hypoxemia. You get this inflammatory response, which is a whole different situation where you have hypotension that then compounds the whole situation. And we don't really have good therapies for that, because ultimately that is more detrimental to the heart as well. So really, we don't know when this starts. We don't know where we are in this process. And we're kind of struggling with a disease process where we just do what we can do. You already saw this slide. This is from 5 years ago. Naveen showed this, that really with the door-to-balloon initiatives, we've done about as good as we can. At 90 minutes, we don't really have significant improvement in the incidence of cardiogenic shock. But I'm not sure that that means we give up. Is that the best we can do? If you look at early presentation versus late presentation on the bottom left, you can see that patients who present earlier, those who recognize their symptoms and come to fruition earlier to the cath lab or to the hospital, have an enormous benefit, maybe a 50% or 40% absolute risk reduction in mortality and in the incidence of cardiogenic shock. So are we missing something here in that? Are we just giving up too early in door-to-balloon initiatives? So as you can see, there are two ways to improve mortality in shock. There is presenting earlier, which makes sense, but it's also hard. Patients have to be aware of their heart condition and that this is a heart attack. Identification of those symptoms in that patient, activate the EMS system, 911, transport the patient, the door-to-balloon initiative. And that leads us to the situation where we need to really tackle patients from when they develop their symptoms, even if it's a false alarm, to fixing their artery. And this will likely result in reduction in early mortality, heart failure, shock, and long-term mortality. Again, we can also just concentrate on the other part, which Dr. Kapoor was mentioning, which is just to treat the shock. Support devices on unloading, door-to-balloon time, in conjunction with that, algorithms and systems of care once shock is developed and team approaches. But I will argue that if we do the former better, you won't need the latter. And so I would argue that these two things need to be done in conjunction, and we should not give up on the former therapies. If you look at patients who present, half the time, or maybe 2 hours in general, is spent recognizing symptoms and coming to the hospital. Then on average, another obviously 90 minutes or 60 to 90 minutes is spent on door-to-balloon time in the best of situations. That does not take into consideration transfers of other hospital patients. So we're looking at a 2 to 3 hour process of these patients by the time they come to us. And the problem is that shock develops at some point in that time course, and it may already have happened by the time the patient presents. And at that point, you have diminishing returns of unloading or other mechanisms. And we already know this concept. If we get these patients earlier, their mortality is much improved. If you get them within this golden hour, their mortality is very low. We've known this from the lytics trials, that if you get them within 1 hour, you don't need primary PCI. And so we have learned this concept earlier, and if you have that, then the patients will likely not develop shock. They will likely not go on to develop heart failure. So I would suggest that that is probably a direction that we should not give up on. So even if door-to unloading is correct, there are significant challenges. Defining and identifying cardiogenic shock that warrants unloading is not precise. And that's why I'm mentioning about the shock definitions paper that myself and Dr. Barron are co-chairing that should come out probably first quarter of next year. There are no real-world powered randomized outcome data. Complications of mechanical support may outweigh theoretic benefits. So we're dealing with a situation where we want to put these devices in, and I put them in myself, but we don't know what the effects of bleeding, of the hematomas, of the complications of vascular injury can be on these patients. And we all know that a patient that has a vascular insult in the setting of cardiogenic shock is pretty much not retrievable. We don't know which devices, if any, fully unload the heart, or what degree of unloading results in clinical improvement. So this trial is an important trial, but do we know that we have the devices that on a microvascular level or on a microscopic level in terms of reperfusion injury can actually do the work that is shown in some of the preclinical data? We don't particularly know that. Cost remains an issue for current devices, and then of course maintenance, escalation, and weaning of these devices is still in its infancy. So until then, I would say that we should still focus and not give up on community awareness, systems of care, shortening door-to-balloon times to remain the priority with a goal of symptom onset to balloon time as low as possible, maybe within an hour. I mean, is it possible? We've done a lot of miracles in medical care. Is it possible to really get the community behind this like we do for stroke, for example? Unloading support on a case-by-case basis, early initiation to stabilize patient in pre-shock or shock, and maybe we should move it earlier. We still need to define that. And certainly later initiation for any patients at risk of developing shock in the next 20 to 48 hours. I would see this as a preemptive strike as well. Patients who we think have no shock right now but may develop it are also patients to be considered. Thank you.
All right, so we'll continue. So I think that it's important to make sure that everyone understands the difference between the term door to support. We're using that in the CSI initiative, and then door to unload in this trial is not for patients with shock. So just to make sure that people understand that when they're seeing any information that comes out about door to unload. So we talked a little bit about the door-to-unload safety feasibility study, the design of the study. This was the pilot concept. It's really meant basically to vet the safety and feasibility of the concept and to get early signs of efficacy. And it's a radical idea that you would put a pump in a patient having an anterior STEMI, but not so radical. We tried it with CRISP AMI. We tried it with the Tandem Heart reperfusion injury trial, the TRIST trial. So we as a group have been thinking about this concept for some time. For some reason, people felt that balloon pump would be fairly benign and would have no major effect and negative effect in terms of risk. But I also know as a scientist, and we get rejection all the time. So this is an editorial from Eric Bates. I would predict that mechanical preconditioning with a percutaneous LVAD will not translate into successful clinical strategy. And so this is editorial work by guideline writers. So we think these are important debates and conversations to have. I got this tweet texted to me. So this is even more conversation out there. So how in hell's name can that ever work? In the active arm, the vessel is blocked for 30 minutes extra. That is so crazy it cannot possibly work. If the trial is positive, I'll present it as a late breaker in a dress wearing a blonde wig. If the p-value is less than 0.02, I'll wear a hula skirt. If it's less than 0.01, I will also wear and use a hula hoop. So my girls were wondering why I was taking pictures of girls doing hula hoops off the internet. This was why. So I'll explain that to them when I get home. But in New England, the mantra is always ignore the noise and do your job, and that's how we operate in our research laboratory. So ultimately, the proof is in the pudding. And so the pilot study was 50 patients. There's a safety adjudication committee, and if there's a safety signal, trial's ending, right? Enrollment completed in May 2018. All 50 patients are enrolled. We've completed the enrollment. The analysis is ongoing now. We should have this data out for you in the fall. And I'll show you two cases that illustrate the concept. So this is a 50-year-old, showed up with no medical history, new onset anterior ST elevation MI. There's all the tombstones that we're all very familiar with, less than 6 hours of chest pain onset. Patient comes into the cath lab, 9:37 is case start. Angiogram, micropuncture access. A V-gram using a pigtail shows the anterior wall is hypokinetic. Impella pump is in. That's done by 9:46. The Impella pump is in. It's activated at P8. And by 9:49, we've got a glide sheath into the radial. So feasibility in terms of timing elements, these are some of the case examples. So now a completely new experience. Impella's in, we're unloading, the LAD's occluded, and we get randomized to 30 minutes of sit on your ass. And basically it's 30 minutes of conditioning. And remember, you can bail out if you think that the patient's not doing well. And I end up talking to Bob or Larry or whatever the patient's name is for about 30 minutes in a very nervous high voice while we're standing there. And then after 30 minutes, wiring this vessel, opening this artery is basically a simple step for us. But take a look at the hemodynamics during the 30 minutes while I was freaking out. So heart rate, 115, There's your LVEDP tracing up above 25, close to the 30 range. This is a full-blown big anterior MI, otherwise known as a BAMI. And after about 30 minutes, heart rate 68, there's your pulse pressure on unloading. Your LVPDP signature now looks like a nice square root. You're down to about 10, maybe less than 10 millimeters of mercury of unloading on that LVEDP. You've got a patient who got 5 mg of metoprolol, IV nitro, BiPAPs off, patient's pain-free. I have not opened the artery yet. Now we go ahead and open the artery, and that's just another, I'll put in parentheses, landmark day, because that's the first time I ever sat around and waited for 30 minutes while someone was having an anterior ST elevation, but with a pump in. And so the way to do this is technical feasibility. It's talking about optimal team dynamics for DTU success. The entire study with a 30-minute conditioning arm after Impella was implanted, 67.48 minutes door to balloon time. So this can technically be done under that 90-minute mandate of door to balloon time, and that's the concept of door to unload. And it really requires your team to basically run these things as practice codes like an ACLS code. I'll show you one more case. So this is a 60-year-old gentleman, hypertension, less than 6 hours chest pain. There's the ST elevations across the precording. You can see it in V1 especially. And this patient comes in, there's your proximal LAD that's occluded, and then your revascularization after reperfusion. The patient, of course, got the pump put in, uneventful CPLE deployment, door to balloon time 72 minutes, inclusive of the primary unloading. And now, it's important to notice how the echocardiograms look. So this was day 3 post-MI. And remember, this is our guy who's on his way to developing that heart failure program we talked about. And 30 days later, here's the CMR. And if you're looking at that CMR, that's a lot of subendo scar, right? It's a good amount of scar. And so what is the likelihood this dude's going to recover, right? Here's his echo, day 90. So there's that ejection fraction that went from here. That's the scar at 30 days. 90 days later, this guy's not getting an ICD. Okay, this guy is not going to be on a 10-year commitment to advanced heart failure therapy. And that's the idea of door to unload. It's not about in-hospital mortality. It's altering the trajectory of post-MI heart failure, going from door to balloon to door to unload to prevent that patient from suffering that 10-year saga that we keep putting our patients through for large anterior MIs that get revasc. And the idea is to take that patient and allow them to recover. And that's the simple concept for door to unload. So it's been a global team of physicians and scientists. I'm certainly not alone in this group, but there are many, many people that I've met who've been working on this for decades, who have a lot more gray hair than I do. Some don't have hair. I'll point out near Uriel here. But basically, we've been working on this for a while, and this is a concept that hopefully we'll have the data for you this fall. So thanks very much.
So I'm going to be brief here, and say that I do think that these debates are interesting, but really I do believe very much in what Naveen is doing and where the field is going. I think the goal really is to identify these patients and figure out when to institute support. We do need to make sure these infarcts are much smaller and that shock does not progress and does not cause the long-term outcomes that we are faced with. The epidemic of heart failure that then fuels transplant, if they can get that. So I think I'm just going to focus a little bit on the real problems right now, which is where's the data. You know, we have some base. You've seen this. Most of the studies they showed you were in pig models, and so there's some basic animal lab data for reduction in infarct size, despite further delay in opening artery. The shock trial. You know, a lot of these trials that came out are really once shock is already initiated, and so it's really too late. The USPELA data you saw in Naveen's slides suggest improved survival if Impella placed pre-PCI in shock patients, but again, it's a selection bias, right? So these are patients who could get it ahead of time. And Detroit National CSI Initiative, it's a good initiative. I think it actually takes all of our information that we have to date and also how we'd like to take care of these patients and puts it all in one protocol. And I think it is a good protocol to go ahead with, looking at hemodynamics, pre-PCI support, and rapid weaning oppressors, which are deleterious to increase survival compared with historical data. But the real problem with all of these is that there's low strength of the evidence and really a lot of potential risks, and that's the hesitancy in using these devices up front. And the hesitancy is not just in the physicians, it's in the CCU, it's downstream, it's in our surgical colleagues, it's in our heart failure colleagues. Some of them want to move on to transplant. You saw that in the discussion about the 3 different people with 3 different biases and 3 different goals. One is to move to transplant, one is to move to ECMO, which ultimately moves to transplant as well, and then here we are as interventional cardiologists trying to recover the heart. And I'm not even sure everybody's rooting for us, besides the patient oftentimes. And these are things that we have to deal with as a culture and as a system. And most of these data are confounded by serious selection bias or team-based aggressive approach, and you really can't read that out. Even the CSI initiative is really, how do we get a really strong team involved and a protocol involved very quickly? And I would argue that that would improve outcomes in almost every disease state that we have. So early presentation, I think, affords much more options. It's likely to reduce ischemic reperfusion injury and ischemic time overall, likely to reduce infarct size, likely to reduce incidence of shock, and likely to improve mortality. And we don't really know how much this can happen. So I don't think that we should give up on these. And I also think that although what Naveen and others are doing in this field is vital, I would hope that it would be required for a lower and lower subset of the population. Our efforts really should be focused here, and I'll speak to myself as well, because as I'm going through the definitions paper, I would love to have most of these patients in pre-shock or in early identification of shock as opposed to full-blown shock, where really we're spending a lot of money and spending a lot of time and effort and energy on a disease state that is very hard to move. And focusing here, I think, would eliminate need for anything else downstream, just like the golden arrow lytics would and could have avoided primary PCI if we got there. And the randomized control data, I think it will be very interesting to see what Naveen comes out with in his study. I think that'll be very helpful to determine what we can do from an infarct size standpoint, which ultimately, obviously, will improve outcome in these patients. The randomized control trial of STEMI patients at risk for shock or with documented shock undergoing unloading versus dirty balloon is needed in order to prove this hypothesis. I guess the question of the unloading of the 30 minutes, is that absolutely vital or not? Do you need that to prevent the infarct size escalation, or do you not need that? That's not clear. These trials should be powered for combined efficacy and safety outcomes, including access site complications. As we learn, these kinds of bleeding and other complications do affect mortality. The secondary endpoints have to be infarct size or ejection fraction at a pre-specified time point. What is that time point? Not clear. And I really do want to focus on the definition of shock here. That's one of the problems with a lot of these trials, is to properly identify the right patient. These are anterior MIs, not necessarily with shock, but probably the ones that will have 30-40% of their myocardium in jeopardy and result in shock. And do we have the devices that can really do this? Are we really moving ahead, hopeful that this will work, as opposed to, and then we may have a concept that failed, not because the concept is wrong, but rather because the timing is wrong in terms of technology and identification of the patient. Thank you.
Thank you. We're running a little bit behind, so maybe I'll just take a quick show, ask for a quick show of hands. Who thinks we'll get to see the hula skirt and hula hoop at the late breakers? Any hands that we'll see a positive trial? Got a few hands up. Who thinks no hula skirt won't work? Similar, few votes, a lot of abstentions. So, that being said, moving on.
I think the key thing is it's a pilot feasibility safeties trial, and then hopefully with some positive data would then set the stage for a larger trial.
Well, and I think even if it's suggestive, I think the potential for benefit is enough that it would be worth continuing to pursue it. So I'm hopeful. I'd love to see a hula skirt. I've got enough heart failure patients to see already. If we can slow that stream a little bit, it wouldn't bother me in the least. So I think next I'd like to move on to our second debate, which is about which device for severe shock. And first we'll have Dr. Dangas, who will be speaking on behalf of Impella.
Well, great. Thank you for the invitation to be part of this great session. Very dynamic exchanges already, and I'm sure we're going to have some more. I will further look at this data in a little bit different way about this debate that's about to start. As we've already discussed, risk stages and outcomes of shock can be confusing, and that you can see that the risk factors for development of shock are very different. The stages are also very important, and the risk factors for mortality after you get into shock, they're also very debatable. Obviously, if you have an all-comer situation and severe shock means terminal shock, we're not going to go very far. We all hope to target the impending shock or a little bit into the established shock once all these initiatives go forward and we know what we're talking about. An example of a great paper we had in JACC this past year was from the IVP Shock 2 trial that had nothing to do with the device specifically. They just went ahead and categorized risk factors for shock according to the multivariate analysis in order to understand which is the more severe situations and which could be the milder, earlier ones perhaps. And you can see that some laboratory values that we do check matter a lot, as well as laboratory values we don't check, such as a lactate, for example, matter quite a bit as well. We all know that we wish to intervene early. At the same time, we also want to intervene early in salvageable cases. And therefore, we have to do something that is important and relatively easy to do, as many cases may be complex and on their own right, and they could also have some limited access as well. We've already seen, and I will remind you, that the power of the heart has a lot to do with survival. Let's remember that. The Impella LV support device has shown to have superior results in respect to this parameter in a randomized trial. And this was accompanied by the fact, the explanation that it produces a decrease in LV diastolic pressure and volume, and therefore, with the support or even the similar level of the systolic or the diastolic blood pressure, it does increase and enhance the coronary perfusion pressure. That is a difference between the diastolic blood pressure and the LVDP, and therefore helps the heart recover for some time. It has been associated with about a 30% decrease in hard endpoints. MACE, including large MI, is in this analysis over the classic balloon pump. And by multivariate analysis in the same randomized trial, that was the only factor that was protective of how the patient would do further down. So we do have some secondary analysis with respect to this utility of this particular device. Going into as a prelude that perhaps what will happen, we will hear later in the fall of this year, a single-center cohort study indicated there may be something happening with improved mortality with the unloading pattern with this device. When we go to ECMO, which is a modern form of a cardiopulmonary bypass, what is added on is the oxygenation part. It's also added on a lot of tough cases already treated by ECMO in various settings, pretty much advanced, salvage, perhaps even, as I said, terminal shock in my earlier slide. And no wonder there's a variety of widespread complications or adverse outcomes associated with this device, no yet randomized trials of any kind to show that. What are the differences? We're looking into Impella versus balloon pump. The Impella has a direct LV unloading. On the other hand, ECMO does not do that. I'll show you the hemodynamics right after. We can potentially support both hearts with the two Impella devices and kind of treat those separately. They're compatible with oxygenation with VV ECMO, but when respiratory support is mandatory, definitely ECMO is the device that assigns that, which leaves the cases that do not need respiratory support as a mandatory part of the equation as a good candidate for Impella type support. It does require fluorophore insertion of the Impella, whereas ECMO does not. On the other hand, the ECMO requires the perfusionist help for the most cases. And this is a concept that the hemodynamic concept of ECMO is a little bit different from Impella, that it does increase the end diastolic volume and thereby increases the wall tension and therefore doesn't exactly have the favorable effect in the coronary perfusion pressure that I showed you earlier with Impella. Hence, you may be resting the body, resting the tissues, resting the brain with oxygen and all these things, but if the heart is in the core of the shock etiology of this patient, not necessarily will the heart get better or recover with this modality because you don't directly impact the coronary perfusion pressure. And indeed, in a recent article, less than a year in the European Heart Journal of Heart Failure indicated that in patients with the ECMO type support that the isolated LV failure was a problem as far as the outcome. So there has to be something to be done about that. So in concluding my first and short and pointed part of this debate, we know that the different cardiac power index support is provided by various hemodynamic devices. Clinical trial results thus far have failed to provide unequivocal evidence for routine use of any such device in any specific population. And the key word here is routine, because they target a little bit of a routine use population. I think these kind of trials need to be a little bit more non-routine and more well-targeted to specific characterization. Early revascularization with shock is very important. A decrease in LVEDP, according to my opinion, is very important in driving enhanced coronary perfusion, and a selective LVAD can help in this situation if it can be inserted percutaneously and easily. And it will get even better if the access size gets even lower or smaller. Current use of hemodynamic support devices should be individualized after taking under account the risk of PCI, the clinical presentation of the LVEF, the arterial access, and if there's no need for oxygenation support, the choice is clear, in my opinion. Thank you for your attention.
All right, so now my debate, my turn is I'm gonna take the side of ECMO. Unfortunate for me, George is a very nice guy, so when you don't have a scientific argument, basically you attack the person. So, so I'm gonna start with that. These are my disclosures. And if you notice, there is no Impella or ECMO or any manufacturing devices. So George is a Greek. And although he is the son of mortals, George, according to Homer, was the bravest, the handsomest, greatest warrior of the army of Abimed in the Trojan War. So the irony, when I looked for a Syrian hero, because I am Syrian, I found this guy, 3,500 or status of refugee. And the irony is like not lost on people who know what's happening in Syria. Half the population is refugee now. So that's it. I like to point out, George was butt naked with a diaper rash. So if you really have a patient with cardiogenic shock, okay, you really need power. You cannot depend on a piddly device that would not provide you with enough support. If you have a large-sized person, you really have a significant hemodynamic deficit. This patient needs 4 to 5 liters to support him. He cannot be supported with 2 or 3 liters. So you need to think of heavier device than the Impella. And I agree, ECMO has no randomized trials. However, there are really credible studies that show that ECMO is actually supportive. And these patients who come with a cardiogenic shock, their choice is either dying or have a hemodynamic support, and their survival of 50, 60%, but that's beats the heck out of 100% death. And I'd like to point out, although ECMO does not have data randomized trial, we do have randomized trials for Impella, right? This is actually balloon pump study that showed the balloon pump does not show any benefit in cardiogenic shock. This is actually comparing Impella to balloon pump, and also Impella to balloon pump has no benefit in those patients who have hemodynamic support. So most importantly, the difference is real support versus no support. And actually, I couldn't put it any better, and thank you, Ajay, for arguing my point, because when his patient blood pressure was 200 with a 3-vessel disease, he put an Impella, right? But the second patient he showed that has 0 blood flow to the heart, Ajay and his really team of luminaries, like this is Colombia for God's sake, they put ECMO, right? And both patients survived, but probably because the hemodynamic deficit, they measured the therapy to the hemodynamic deficit. So the difference, ECMO can provide you 4 to 5 liters per minute of actual cardiac output, in addition to whatever the heart can muster up and pump. While you have to remember, when you put an Impella and you read in the council 3.5 or 3, this is actually algorithm calculated, not actually calculated, as opposed to ECMO. The second thing, you have to subtract that from the cardiac output. Really, that's not the actual cardiac output. It's not like if the cardiac output was a 3 at baseline, you put an ECMO, it becomes 6. Because what happened, the ECMO, as George pointed out, it's actually unload the ventricle, so you have less workload, but not actual hemodynamic support. The ECMO is independent of the heart function. So if you have a VT, if you have a RV failure, the ECMO is going to continue to support, where Impella does not really have a support in patients who have VT. You can actually talk to the patient while they have VFib on ECMO, even in patient with cardiac arrest. So patient with a profound cardiogenic shock, you really cannot depend on an Impella. Most importantly, those patients who have lung injury. A lot of our patients develop pulmonary edema. They need oxygenation, so ECMO will work. And when you have biventricular failure, ECMO will work. And admittedly, I would say ECMO is associated with increased complications, access site complications, but ECMO comes with actually solution for the limb ischemia. If you notice here, there is a side port here. I don't know if you can see my, okay, you can. Side port that actually goes to antegrade sheath, and look at the leg here is very, very pink, where it's actually very difficult to do that with Impella. So what the truth about Impella? Everybody using Impella, 75,000 devices deployed, not a single randomized trial in cardiogenic shock, really. And even in a protected PCI, actually the trial was negative. It's only post hoc analysis in 90 days and per treatment arm that showed benefit. So in reality, the emperor is naked. I gotta click escape. Oh. Okay.
Great, definitely the debate has heated up. There's no question about that. So, well, I mean, we have to concede some fights around the areas of the battlefield, and clearly the oxygenation was identified an area that I'm not really fighting about that in those mountains, so to speak, since we're in Colorado. But as we talk about the battlefield, we also have to understand how the troops are approaching the battlefield. And although there is a lot of cardiac output delivered by these cannulas of the VA ECMO, those cannulas are actually delivered in the iliac arteries, or maybe the distal abdominal aorta. In my reading of anatomy, the blood was supposed to go the other way. It was supposed to go from top to bottom. So right now we're having this flow, but it kind of goes from bottom up. And there is a situation there that the last place to reach is actually the ascending aorta, the coronary arteries, and even the innominate artery, which is extremely important circulations of the brain, and the heart may actually not end up getting or realizing that much flow that is delivered in the distal abdominal aorta or the iliac artery. All right. So that's why one can see if the possibility of adding an Impella to ECMO, if all that's so great in the ECMO, then why would Impella make any much difference in the outcomes? It shouldn't. Apparently there is, because it addresses this part that I said before regarding the enhancement of the coronary perfusion pressure by decreasing the LVDP and thereby enhancing its difference from the diastolic blood pressure, because there may be a lot of power even in a lion. But I do recall from elementary school the myth of Aesop that even a little mouse was able to entrap the big lion in order to escape the net that it had captured it. So again, you need, I think, a very smart way. No, power is not everything. How you apply to it and how you combine it is the key. Therefore, I think we have to focus on the hemodynamic support of how much support is necessary at a certain part of the patient's treatment. How can we prioritize the device use? And if we had a good way to actually remove impella sheath, and when needed, supplement on site with a VA ECMO possibility, that exchange might have led to significantly higher increase of both devices, I think. Which patients should get upfront treatment with an LVAD? What is the optimal use of Impella support, standalone or in combination with the RVAD? How do we manage the biventricular failure? And I'm coming a full circle that none of these situations are ever going to be solved because they're complex and complicated and interrelated, and we have to start dealing with, again, the very first slide. That's why I have an inter-society initiative, other initiatives to try to figure out what are the stages of shock that we can all agree, so we can stop lumping in terminal shock in our trials and claiming no difference. If the shock is terminal, nothing could help those patients, or very little perhaps, or a palliative care consult may be more appropriate. And therefore, we can figure out on the risk factors of mortality the appropriate risk scoring. We have to start to routinely measure these parameters, and we start to make some progress in a regimented way. Thank you for your attention.
All right. So I think I won the debate for just the mere fact that George is so smart, he used long sentences. I am just kind of Joe Schmo who bust arteries open, and I use short sentences. So I gotta admit that the hemodynamic support by ECMO, if you actually able to use the 5.0, it's actually provide excellent support, and we are just going to publish a paper about transcaval access 5.0 Impella, and this is to provide enough support. And that actually proved my point. The available CP ECMO and 2.5 ECMO might not be enough in those patients who have significant hemodynamic deficit. But how I see it nowadays is not ECMO versus Impella. George could not say it more elegantly. It's actually, we have to work together to save the patient. And a lot of those patients, when the ECMO goes in, there is significant ventricular loading and increased wall tension, which actually gonna cause significant increase in oxygen consumption and oxygen need. So if you add an ECMO if you add ECMO to Impella, now we have a new term, call it ICPella, and that actually a lot of times works better for the patients. At the end of the day, this is the cardiogenic shock is a spectrum. There is a pre-shock, and there is shock, and there is shock, and there is deep shock, and so we're really still scratching the surface. And if it wasn't for Naveen Kapoor and Bill O'Neill and Harry and the other guys' work, we would not probably start this journey. And soon enough, we're going to have much more data, and just keep tuned. Thank you so much.
Any other comments from the panel before we move on, or any questions for our speakers? All right, hearing none, I think we'll move on to our final speaker. I'd like to invite Dr. Cohen up to speak about the importance of the shock team.
Thank you so much. It's great to be here. I think the shock team has become very important because all these machines that were discussed, they require significant attention and vigilance and expert skills. So most of the things that you need, you can find in this statement that we put together last year, published and led by Sean Van Diepen from Alberta in Canada. So, and we, in this statement, even though we don't dictate any type of guidance, or we don't dictate what should be done, at least we raise some of the issues that can be taken into consideration. So one of the important things we need to understand is that there's a volume-outcome relationship in the management of cardiogenic shock. These volume-outcome relationships have been studied first in surgical procedures. Now it's being studied with surgeons. We studied with PCI. It's a little bit controversial, especially in a country that does very little with operators that do very little PCI. But you can see here that using more than 106 cases as a reference, the mortality here is 34.4%, and it goes 10% higher to a hospital that treat less than 28 cases per year. So that's an important thing to consider. So why would that be? Because large volume sites are more likely to be academic, located in urban areas, and probably serve as referral hubs. And that's the first thing that I'm trying to hint, is that the spoke and hub model may be a good model to go to develop these teams. Patients at high volume hospitals are more likely to receive evidence-based care, prompt revascularization by high volume operators, and this is what you need. You need expert operators to take care of these very sick patients. High volume hospitals may include multidisciplinary teams who more frequently implement mechanical circulatory support, as the devices that were discussed here by Carl and George, and can care more efficiently for patients with multi-system organ failure. And then high volume hospitals can be hubs that are integrated with EMS and spoke centers with clearly defined protocols for early recognition, management, and transfer that can improve patient outcomes. So the guidelines have not been very helpful, and I'm glad that there are some initiatives by the societies. But what we do know about the management of shock is that it's important to revascularize irrespective of time delays, and that's a Class 1B indication based on the shock trial that was done like 15 years ago or more. The use of balloon pump is highlighted in this guideline, but there's not much about alternative devices, or there's not a description of alternative devices for refractory shock. This. And then what to do about these patients? They recommend transfer to a PCI-capable hospital for coronary angiography in patients that develop cardiogenic shock, but they don't go beyond what is PCI-capable. I mean, a small hospital is PCI-capable nowadays. So there's no additional guidance for patients who develop refractory shock after primary PCI and insertion of a support device. So all the development of teams, these are data from the shock trial on transfer. And so a significant proportion of patients were transferred within that trial. And in the IVP arm, 77% were direct admit, 53% were transferred. And in the revascularization arm, 42% were transferred and 58% were direct admit. And those patients that were transferred tended to be a little bit younger, a little bit healthier, but they did well after transfer. So that hub and spoke model can work for the management of shock. We have learned from post-cardiotomy cardiogenic shock with Bridge to Transplant Network that was developed in New York. This was published a few years ago, in where they take patients with LVADs and they send them to more complex programs. I mean, the cases are not that many, but highlights the need of teams that can work on the transfer of these critically ill patients, and how the communications need to be established between the referring center and the referral center. So they developed their own protocols as a bridge to transplant network, and they found that that's associated with improved survival, and they have their own protocols, as you can see there. Then there's another system that was used by the group in Mayo Clinic in Phoenix, in Arizona, where they deploy a team to the spoke hospital, and then they can stabilize the patient, put the patient on mechanical support, either CentriMag, Impella, Tandem Heart, ECMO, and then they can transfer to the hub hospital where the patient can receive more care. So this is this is a timeline. So they have a patient with an adverse cardiopulmonary event, then the consultation goes on, then the approval for emergency privileges and insurance is obtained, decision made for the traveling team. The team arrives in the referring hospital, and then they decide what to do, and then the patient is returned to the hub hospital for a recovery versus transplant. Similar thing has been done in Paris with a cardiac rescue program, where they have special mobile units that can deploy a team, insert mechanical circulatory support, and then transfer to a hub hospital. They developed a form just to measure what they do, because this is very important. And in that program, the mortality of patients of more than 62 years was high, 100%. Patients that had to have resuscitation had high mortality, but the other patients, the patients that survived, had a survival of 93.8% at 1 year. So that highlights the importance of those critical early moments and having teams that can care for these patients. So for the scientific statement, we developed this graph that shows that there are many ways to get to the hub cardiogenic shock center, and there are multiple team interactions. See that we're all men in this panel here. So somebody looked at this slide and changed it, and have a female referring in the receiving end of the hub hospital. So anyway, so patients can come from the ambulance, from the field. They can go for the non-shock spoke center, or they can go to a not PCI capable. And there are many ways, but it's important that the shock mobile unit will, and the two teams will establish communication and then decide on what to do with the patient and have expert care. There are also some issues on the training that doctors have in the teams caring for patients. So there's been an appraisal of the need for critical care training for coronary care for the CCU doctors. And this is something that is becoming more important. So it seems that a closed unit staffing model is associated with improved outcomes. The cardiac ICU seems to be best suited to centralize the cardiac care of cardiogenic shock patients, but attending cardiologists and teams may not have the dedicated training to address multi-organ system failure associated with cardiogenic shock. On the other side, the controversy is that MICU may be better suited for management non-cardiac organ failure, but then the MICU trainees are not prepared to manage cardiovascular illnesses and perform common cardiovascular procedures. So there's an emerging evidence that transition from an open, low-intensity care model to a closed unit model with care led by dual-trained cardiologists, intensivists may improve outcomes, and that highlights some aspects of the team. So these are models of staffing for the CICU or ICU according to the hospital. So what we should aim at is to have, if we're going to care for patients with cardiogenic shock, is a high-volume cardiovascular center with around-the-clock house unit coverage by MDs, residents, PAs, nurse practitioners, one-to-one nurse-to-patient ratio, mechanical ventilation, invasive cardiac monitoring, transvenous pacing, all sorts of support devices, medical consultants that are available and are on site, and then ancillary personnel, physical therapy, occupational therapy, social work, and then end-of-life decisions are very important, and we need to have a very strong palliative care team. In the end, we have to be careful on how we go about public reporting, because that can deter doctors on how to deal with these patients, and then they may tend to undertreat because nobody wants to be nailed for having a bad outcome in a patient that was sick in the first place. So one solution has been to take these patients away from public reporting, and I think that the National Cardiogenic Shock Initiative is a wonderful initiative to start protocols around the country and improve training and discuss the care of these patients. So in conclusion, I think that cardiogenic care requires a dedicated teams that can translate the success of Mission Lifeline for STEMI and out-of-hospital cardiac arrest with single activation. There's a volume-outcome relationship, so we should concentrate the care at high-volume centers with trained, proficient staff. CIC models of care are in transition, and the critical care training is needed for cardiovascular specialists. Transfer for cardiogenic shock is possible and associated with good outcomes, and I think new quality initiatives across the country can introduce protocols, collect data, and standardize care. Thank you so much.
Thank you. Are there any questions from the audience? Otherwise, I have one. I'm just curious about, in your center, how do you have the structure with the CVICU? Do you have dedicated cardiac intensivists? Do you have dual boarded people? How does your center do this?
So we are a 3-hospital campus. So we have a VA, a university hospital, and a county hospital. The county hospital has a transplant program, and the transplant unit and that special CICU that is mostly surgically led with anesthesiologists and intensivists is the way that it goes. We have not transitioned yet, and we have not found yet the way to transition to a CICU, a cardiac care unit, with dual boarded staff.
And this is something we've been spending a lot of time discussing in our practice, and one of the things that's just an operational challenge is there aren't a lot of those people out there.
Correct.
And this is very high acuity care, and so you can't just hire one and expect them to provide 24/7 coverage.
But there's a group. So if you look at that statement, most of the co-authors that are not interventional cardiologists like me, they are dual boarded. And there's a new breed of cardiologists that are getting, and more programs are opening. So I think we're at the beginning of the dual boarded cardiac intensivist. And we're recruiting a new CSU directorate. And one of the requirements is that this director is dual boarded because of the acuity of the patients.
Great. We have a question in the front here.
The question we have is, in our program, sometimes the patients in the emergency department and the emergency room doctors get the ball rolling, and we get down this path where we kind of are well into treating these patients, going to the cath lab because of our door to balloon time initiative, and in retrospect, you feel like that patient should have never even gone to that because of their frailty index, or, I mean, what sort of things have you done in your program to try to, with education, or try to stop that process from being initiated to begin with? Any advice from that?
Well, we haven't done, so I mean, these are proposed models of care. It doesn't mean that we have them implemented all across the country. I think that different initiatives going on will end up implementing, and I think there's also leading initiatives from professional societies like American Heart Association. I am in charge of the acute care committee, and we're leaning towards that. I think the model of care for this patient has to change. Whether or not you take your patient who is very sick to the cath lab, that's a decision that has to be made as a group, and depends on public reporting, depends on your willingness to take these patients, and depends on the resources you have available to take care of these patients. Sometimes you may want to refer these patients and develop a hub and develop relationships with a hub hospital that may take your sick patients. We transfer our sick patients that are in refractory shock across the street from our hospital. We can do up to Impella. We are implementing ECMO now. We have a traveling team that will deploy ECMO in my hospital, and then transfer to Jackson, where the surgeons can take over the care and do more advanced and destination therapies or transplant.
Dr. Burke?
Thank you, Burke from Minneapolis Heart. A couple of comments on this. This is obviously our next big issue that we need to tackle, and it's imperative that we have procedures and protocols in place where not just cardiologists, but intensivists and the ED physicians are all involved. We've started a program that we call SWAT, Shock Without Trauma, because so many of a third of shock patients are cardiogenic. So that means 2/3 of the patients don't have anything to do with the kind of things that I can do to make better. But we need to be able to identify those people better in the field so that they can be triaged appropriately. The other thing that I think that we need to do is we need to have a national initiative just exactly along the trauma lines. We need to have shock centers that have exactly level 1, level 2, level 3, exactly what they do for trauma, and have requirements for certain people in the house, certain abilities for different capabilities, and referral centers.
Yeah, and let me add to that. I think that there should be a single activation code when you have a patient with shock, so the whole team that concentrates the volume, the full team that concentrates volume will deploy and take care of that patient.
That's right. Actually, we have, with the Shock Without Trauma protocol, the patient is met by an intensivist and an ED physician in the ED, and the cardiologist is called if they believe that it's a cardiogenic shock type of process, so that the cardiologist can meet the patient in the ED as well.
Yeah,
So in our center, and this is call for action for all of us. First of all, there is a paper by Mauricio about the organization of cardiogenic shock. It's amazing paper, really good. It's a must read for everybody who deals with cardiogenic shock. The other thing, you really have to look at your local resources, and the worst thing you can do is sit on a patient with depressors. If you don't have escalation in your center to ECMO and a VAD, you need to partner with a center that has an ECMO and a VAD. But the more important, most of our patients who transferred to us, they waited 24 hours to 2 days before they transfer. And by that time, the shock is not reversible. They have to move as soon as possible. The longer you wait, this is similar to the golden hour. I don't know if you guys, I used to be an ER doctor and I had ATLS, Advanced Trauma Life Support. There is a concept called the golden hour, meaning if the patient comes with a trauma, the best hour to save him is the first hour. After that, you cannot actually reverse the inflammatory process, the shock, all the other issues that could ensue, and the end organ damage. You have to act really fast. And the worst thing you can do is wait on those patients.
All right, it's been a fantastic discussion. I hope everyone enjoyed it and learned as much as I did. And we'll now take a break. Thanks to our panelists for enlightening us.